Hi, everyone. My name is Caroline Arnold, and welcome to our Cleft Lip and Palate in Kids Choosing the Best Care webinar, Facebook Live and live streaming event. Today, I'll be your host, and I'm here with the expert Dr. Carolyn Rogers. Do you mind introducing yourself, Carolyn?
I am Carolyn Rogers-Visma, and I'm one of the pediatric plastic surgeons at Boston Children's Hospital.
Thanks. So we got some great questions prior to this, so we'll get kicked off today with our first one. So what do you do with a new cleft diagnosis?
Okay. So I would say that this is a great question. This is going to be the first of multiple events, and we really wanted to focus on the earliest part of care. And if you're watching this, you may already have a cleft diagnosis yourself. You may have just found out about a cleft diagnosis in your baby. I want you to pause for a second and just know that whatever feelings you have are valid. There's a lot of great medical care bottles, things that we're going to talk about, but that doesn't mean that this isn't a lot to go through. And I just want you to know that what you're feeling is real and it's important, and that kind of a feeling matters. I know it's scary the first time you hear news about your baby, and you might be hearing it about an ultrasound, around the 20-week mark. And if that's the case, you're probably hearing about a cleft lip. You might be learning about it after birth, in which case your baby most likely has a cleft palate only. And regardless of which time you're at, both of those times are really challenging to begin with. And so we recognize that it's a lot to learn about a new diagnosis. When you find out about a diagnosis of a cleft at your ultrasound, it gives you a lot of time to prepare. And I'd say that's one of the probably best aspects about learning about things early. If you were to learn about this in the greater Boston area, you might be referred for an MRI. The benefit of an MRI is that we can tell you a little bit more about the extent of cleft, what type it is, and also tell you about whether there are other things about your baby that we should be looking out for. If you live in a place other than the East Coast or a large metropolitan area, you may not have access to an MRI, and that's okay too. Simply knowing that your baby may have special needs for feeding and care after birth is very important at all, just so that you can prepare. In terms of thinking about a new diagnosis of cleft palate, we often find those when babies are not feeding well shortly after delivery. And unlike a cleft lip, which is obvious, you probably won't see it unless you take the time to really look in the baby's mouth. And I would say that some clefts are small and hard to figure out, and some clefts are very wide, and you might see it the minute that your baby cries initially. When we see a child who has a cleft lip or a cleft palate right after birth, we're often focused on feeding because we want to make sure that a baby is getting nutrition and is growing and is able to do all of the things that any other baby should be doing.
Thank you so much. And what do you look for when you're looking for a cleft team? Any tips to give to parents when they are looking?
Yeah, I would say that the most important things to look for are experience and kind of treatments available. If you're looking at teams, ask about volume numbers. How many babies do they see with clefts a year? Certainly, cleft care is like everything else in medicine, where volume and experience tends to translate into better outcomes and more options available. I would say another thing that is worth looking for is a team that you click with. Cleft care is a long journey. If you're in the thick of it, you understand what I mean. It starts oftentimes before birth, but can go until kids are 18, 20, and even older, just because of the nature of the diagnosis and the things that are affected. And so finding a team that is not just experienced, but that you feel comfortable with is important, because you're going to be seeing all of these different providers over many, many years. And it's a journey that we want to be a positive one for you. And so being with people who you feel can support you is very important.
Awesome. Thank you so much. And then do you kind of look for how many cases a cleft team should have per year?
Yeah, I would say that With respect to surgery, there are numbers that have been shown by research to be numbers that translate to better outcomes. And we typically think, 40 cases a year, give or take a few, is the number that is needed to have sort of a top-notch surgical outcome. And I would say that most centers that have surgeons who have numbers like that will have access to a lot of different treatments. And so those are the kinds of things to ask for. We have really focused on that at our center, and I lead the outcomes research related to cleft care here. And so we've taken the time to post our outcomes and our numbers on our website, because we feel like this is something that we want you to know about if you're going to come to see us. And if you're not coming to see us and you live somewhere else, these are things to ask your team about. So that's kind of what to ask for.
Awesome. Do you mind touching base kind of on the different types of cleft lip and palate?
Sure. So I'm just going to share my screen and pull up a couple of pictures. I would say first, you might just be wondering, what is a cleft? Why do we call it a cleft? There are lots of different kinds of clefts. In medicine, we use cleft really to describe a gap or a division in tissue. There are clefts of the lip and palate, but you can also have clefts of the larynx, which is the voice box in the throat. There are clefts of the hands and the feet. There are clefts of the eyelids. And so really, we just mean gap when we're talking about cleft. I'm just going to pull up this share screen and just talk you through what we talk about when we're talking about cleft lip and cleft palate. So when we talk about cleft lip, we're really talking about a division in tissue of the lip itself that may go all the way up into the floor of the nose, and it may also involve the gums. And there are terms you might hear thrown around like incomplete and complete. Well, an incomplete cleft lip literally just means a cleft that doesn't go all the way from the margin of the lip up to the floor of the nose. So it could be just what we call a microform or a very tiny cleft, or a wider incomplete that goes, pretty obviously part of the way up the lip, but not to the floor of the nose. There are also complete cleft lips, meaning that they go all the way through the lip into the nose, and they involve the gums as well. And they can be both unilateral, meaning one-sided. So that's all of these pictures here on the left, or they can be bilateral, which means two-sided, or involving both sides of the lip. Why does that matter? Well, the surgical treatments are different for the two, but we also think about feeding a little bit differently in the two. Babies who have a unilateral cleft lip with a cleft palate will be great candidates for certain kinds of feeding devices like the Dr. Brown specialty feeder, whereas babies who have a bilateral cleft lip and palate, because the front part, what we call the premaxilla, is a little bit more flexible and the cleft in the palate tends to be wider, they may be more candidates for what we call the Medela special needs or Haberman feeder. When we talk about cleft palates, it's a little harder to take a picture of, so I'm going to use these illustrations. But kind of like a cleft lip can be very small or very big, a cleft palate can be very small or very big. Over here on the left is what we call a VO1 cleft palate, which is just a cleft of the soft palate only. VO2 means cleft of the hard and soft palate. And then VO3 and VO4 simply mean a combined cleft lip and palate. So in the case of a unilateral or one-sided cleft, it goes through the uvula, the hangy thing in the back of the throat, the soft palate or the muscular part in the back of the roof of the mouth, the hard palate or the bony part, and the gums on one side. And in a bilateral cleft lip and palate, it goes through the hard palate and gums on both sides. People often ask also about cleft gaps and what does that mean and how is it relevant, for early diagnosis of my baby. And the bottom line is it doesn't mean a whole lot. Sometimes an ultrasonographer might measure a gap in the lip muscle or the lip tissue, for example, from here to here. That's not super important in thinking about how your child will be treated, because as you'll find, when a baby smiles or opens their mouth, the space between the parts of the lip change. We care a little bit more about gaps in the gums. So this is one part of the gums here. This is the other part. And so just eyeballing this, I would say this is probably about a 15 or 16 millimeter gap. And this is a baby with a bilateral cleft where there's no gap on one side and probably about a 10 or 12 millimeter gap here. The reason a gap matters is that sometimes it might tell us about whether your baby is a candidate for some type of pre-surgical orthopedic device, like a Latham appliance or NAM or lip taping, or even the Dynacleft, which is a nasal elevator to help shape the nose, and is also a kind of stretchy lip tape that you might use.
Awesome. Those are great visuals. Thank you so much for sharing those. And then kind of one final thing we just love to touch on, just talk about the surgical journey that patients and families go through.
Sure. I would say that the first thing we really care about is just making sure your baby is doing well. One of the things I think is important to know if you're a parent who's experiencing a cleft is that it's rarely anything that you did that has anything to do with why your baby has a cleft. There is this parent guilt. I experience it as a parent too. And I know it's hard to shake, but clefts happen for a combination of many different reasons, and we can rarely pinpoint one. So when we first meet your baby, we want to make sure that he or she is able to feed and gain weight well. And that's really the focus until we know that they're doing okay. And so when we first meet your baby, we'll watch them feed. This is true both for cleft lip and for cleft palate, as well as the combination. Babies with a cleft lip only often can feed very normally, both by breast and by bottle, whereas babies who have a cleft palate in most cases will have difficulty with breastfeeding. And so we'll focus on special kinds of bottles that have one-way valves that will allow your baby to either get milk or formula by compressing the nipple or by you squeezing the nipple. Once we're really confident that your baby is gaining weight well, if they have a cleft lip and it's a complete cleft, meaning they have a gap there, we may refer him or her to a dentist to be evaluated for a pre-surgical device. And the goals of all of the pre-surgical devices are to put the gums into a better position for repairing the lip, and also to help the nose to have a better shape. And there are many different kinds of devices. What you might be offered will depend on the type of cleft that your baby has and what the expertise at the center you are is. But there's not one right or wrong device. If your baby has a cleft lip, in most cases, it will be repaired around 4 to 6 months of age. That might be a little earlier if it's a less severe cleft or a bigger baby. It might be a little bit later for a baby that has a more complicated cleft or who's smaller at birth, either because of prematurity or because he or she isn't gaining weight as well as we want. Cleft palate is most often repaired around 10 months of age, give or take a few months. And this is something that's a little bit more variable and has a lot to do with your child and what his or her needs are. We'd like to have a cleft palate repaired before speech really starts to take off around a year of age, so that all of the muscles and parts of the mouth that they need to make sounds that require pressure are in the right place, so that they can use them normally at the age appropriate time. Sometimes we might find that there are medical reasons that your child shouldn't have surgery at the ideal time, and that's okay too. We really try to find a time that is both safe and effective for surgery.
Awesome. Thank you so much. We actually just got a question in, and it's saying, when you refer to the cleft center, which specialties are crucial to be involved in that? And what are the advantage of having them all in one hospital?
That's a really great question. So I would say that the advantage of having a lot of specialties together is that they can communicate care around your child. There is an organization called the American Cleft Palate Craniofacial Association that actually certifies cleft centers. And to be a certified cleft center, you have to have surgeons who deal with clefts, dentists and orthodontics who can specially treat children with clefts, social workers or psychologists who can help you and your child navigate all of the feelings that are associated with this. otolaryngologists who can help with hearing needs that your babies might have. And those are really the core specialties. Depending on where you are, there are other specialties that could be involved too. In our center at Boston Children's, we divide up surgical care of cleft lip and palate between plastic surgery and oral maxillofacial surgery, such that soft tissue work, so the early cleft repairs and also end stage touch-ups are done by plastic surgery, whereas bony work, so bone grafts to reconstruct the gums, jaw surgery to put the jaws in the right place are done by oral surgery. And we really do this not because either of those specialties can only do that, but because we want to make sure that whoever is offering surgery is doing a lot of it. And so breaking it up has helped us as an individual center to really provide the kind of volume that's needed to get good outcomes. So those are really the things that go into a cleft center. Depending on where you live in the country, you may not have access to a certified cleft center, in which case, you would ideally be in a facility that has social work or psychology, plastic or oral surgery, otolaryngology, and dentistry and orthodontics. But certainly the advantage of being part of a certified cleft center is that those people all see patients together. Even though you may not realize it, we actually talk about the kids that we care for quite regularly. And so we're always treatment planning together. And this can help provide the most coordinated care possible.
Thank you so much. That's the last live question to come through. So if you have any closing thoughts or anything else you would love to share, we'd love to hear it. And as a reminder, this is being recorded, so we will share this with everyone following the webinar.
I would say my kind of final thought, because I know that a lot of people who might be watching this in the future are new parents, this is a scary thing to learn about. It is hard to learn that there's anything that's going to be different about your child. And it's hard to hear that your child needs surgery. And those are feelings that you shouldn't let anyone minimize. Yes, there are treatments, but it's a lot to go through. And when you look for a center, whether it's us or another cleft center, really look for people that you feel like can support you throughout your journey. We're here for you, but ultimately you're the parent, and we're just these people in the background who can provide little tools to help you on your journey, because it is a long journey, but it's a rewarding one. And I always like to talk about all the famous people who have clefts that you just never even know about because they're doing so well. And sometimes parents laugh. I usually say Peyton Manning because he won the Super Bowl. He had a cleft palate. I know that's not popular amongst Pats fans here in Boston. The actor Cheech Marin had a cleft lip. You may not even know about that. But I throw those things out there really to normalize this so that you know that there are people with clefts who are doing great. And it's certainly a long journey to get there. But this isn't something that really will make your child unable to do normal things. Certainly there are cases where clefts happen in conjunction with other issues or as part of a genetic syndrome, and this may not always be the case, but for the majority of families we see, although this is certainly a hurdle, it is just that, it's a hurdle and a long journey. And I want you guys to know that it's going to be okay, and we're here to help you really help your child thrive.
Thank you so much. And thank you to everybody who tuned in today. We hope we were to help you answer a few of your questions. Have a good one.
Meet you guys. Bye.
Bye.